Well, thank you, Dr. Liu. It's really a pleasure to be here. So over the next 30, 40 minutes or so, I'm going to talk about just from a maybe higher level point of view, this problem of hospital-acquired disability. But part of what's really great about being here is, I think, especially in the U.S., a lot of the initiatives to improve this problem have really been sort of isolated and local. And what's really exciting about what you're doing in Ontario is the community-wide effort to work together to improve hospital care, that I think all of you should feel good about being what I think may be the world's premier program to improve hospital care for older people. So it's just really exciting to hear about all the work all of you are doing, and I look forward to learning from you as well. So over the next minutes, we'll talk about 4 broad areas. So first, let's define this problem that all of you are working on of hospital-associated disability and prevention. Let's think about how often this problem happens. Then let's think about who's at risk. And when I think about who's at risk, I think it's you sort of think about this both, what does the patient bring to cause them to bring at risk, and then what do we do to the patient, or perhaps fail to do with the patient to put them at risk. And then let's think about how this can be prevented. So I'm going to start with 2 case presentations, but these are actually the same patient. So I'm going to talk about an 80-year-old woman hospitalized with pneumonia. And I will first present this from the perspective of maybe how the medical intern might have presented the case to their team. And then I'll talk about how the daughter might have reflected on what happened. And a few questions to ponder. Why do these perspectives differ, and who has it right? It's a hint, usually when there's a clinician and patient perspective, one of them tends to be right. So let's start with the clinician perspective. So Mrs. Smith was an 80-year-old who was hospitalized with cough, shortness of breath, and fever. After presentation to our ER, she got a chest x-ray and was diagnosed with pneumonia. So we treated her with antibiotics, and she also was dehydrated and needed more fluids. So we also tanked her up with fluids and carefully monitored that throughout the course of hospitalization. She was in the hospital 6 days later, and everything looked really good at the time of discharge. All her labs that were abnormal to start with were now normalized. Her chest x-ray was getting better. Her oxygenation was normal. We fixed the pneumonia and sent her home. So this was yet another successful hospitalization. So how might the daughter present this? So mom was getting a little frail. She was living alone at home, but was generally doing okay. She had a fall about a year ago, and I was there maybe to help her once or twice a week, but she was doing okay. She was actually managing at home and doing things like going to church and going to her bridge club, things that she really liked to do. But then she got sick, and we brought her to the emergency room, and the doctor said she had pneumonia. So they put her in the hospital, and I just remember lots of stuff being attached to her. She had something monitoring her heart. She had IV sticking in her. They put some catheter in her bladder, and she really hated that one. And then they gave her medicines. So in the hospital, she stayed in bed all the time, and she kind of seemed confused. When we came in, she just wouldn't talk much, which wasn't like her at all. But everyone said that's just the way people are in the hospital. So then one morning they called us and said it was time to pick her up. She's ready to go home, and everything was looking good. But when we got her home, it just didn't feel very good. She needed lots of help. So she really couldn't walk up anymore, and it was actually hard to get her out of her home because she had to walk up steps to get into her home, and she couldn't negotiate that well. She fell a lot, and I had to come and help give her baths and showers, almost every day. So a year later, it just got too much, and I felt bad about the move to the nursing home, but I have my own kids, and I also have my own job that I work full-time, so it was really hard to be a full-time caregiver and, take care of my mom. And she passed away 2 years later. And, it just seems to be that hospitalization was the time point where everything went downhill for Mom. So the doctor's summary is that this is a successful hospitalization. The daughter's summary is that everything seemed to fall apart for Mom after she was hospitalized, and it was the start of a downward spiral. So the question is, who's right, what happened, and is this common? So probably this might be a story a lot of you here just maybe have seen in your own families, but also hear when you talk to lay people about your work. It's actually, even before I went into geriatrics, I actually always heard this story from people that everything was fine and a hospitalization happened and then everything started to go bad. It turns out this is a really common problem. So the medical term or the epidemiologic term we often use to describe this is hospitalization-acquired disability. So this is the well-known phenomenon in which hospitalization often precipitates disability in older persons. And operationally, this means that after discharge, the older person is no longer able to take care of themselves without assistance. So in the research studies we do of hospital-acquired disability, the operational definition is that the older person needs more help with activities of daily living than before they came ill. So if you ask an older person, did you need help bathing? Do you need help dressing? Do you need help transferring out of a bed or a chair? Do you need help toileting? Do you need help with eating? The operational definition is they'll need help with more of these activities after hospitalization and before they got sick. So we use the term disability, which we kind of often think about as somebody who's been in an accident or who's had a stroke. But this is generally for a hospitalization for a medical condition that's not disabling. So it often is the pneumonia, the heart failure exacerbation, the COPD exacerbation. So it's after what we think about successful medical treatment, which maybe technically is successful because the medical treatment that resulted in a hospitalization did in fact get better, even though the patient is worse. So now that we've defined the problem, let's think a little bit about how often it happens. I should also say, it's fine if any of you want to ask questions in the middle. I mean, that's fine. So just feel free to speak up anytime. So how often does hospitalization precipitate disability? Well, the short answer is a lot. If you look at prospective studies of hospitalization, about a third of patients over 70 will report that they have more disability in activities of daily living after the hospitalization than before they got sick. Once you get past the age of 85, over 50% will report more difficulty or disability in activities of daily living. So it's actually more likely than not that an 85-year-old will have this problem of hospital-acquired disability. So what I'm going to do in terms of thinking about this problem is I'm going to go through a study we did a number of years ago that describes the prevalence of hospital-acquired disability, but we're going to disaggregate this and think about when this happens. So this was a fairly simple study design. This took 2,293 patients in Ohio. And at the time patients were admitted, we asked either them or their family member how much help they needed in activities of daily living before they got sick. We operationalized that as 2 weeks before admission. So that's what we refer to as baseline here. Then we asked them again how they were doing at admission, and they were asked again at discharge. So I'm going to disaggregate this, but the bottom line from this study was 35% of patients by the time of discharge needed more help in activities of daily living than before they got sick. So this study may have been the largest one of hospital-acquired disability, but what's interesting about this is we were hardly the pioneers in this area. We were not the first. and we were not the last. What's kind of striking is this statistic of somewhere around a third of patients have hospital-acquired disability. It's a remarkably durable statistic. Similar findings have been present for at least 30 years. So decades before this study, this was found, and the decades after, people keep finding the same thing in the United States and Canada and Europe and Israel and Asia. No matter where you do this study, this seems to be a durable worldwide phenomenon and problem. So let's think about what's happening over the course of sickness. So let's first talk about what happens from the time somebody gets sick to the time they're admitted to the hospital. So we often focus on maybe disability that happens in the hospital, but it's important to remember that actually a lot of the disabling has happened even before the patient has hit your door. So among these 2,200 patients at the time of admission, 57% at the time of admission were stable in function, and 43% reported that at the time of admission they had worse ADL function than their baseline. So this is kind of interesting in that it's about 50-50. This is actually not something that I was taught in medical school to measure, but I think one could think about this if one is trying to prevent this problem. This is a rather fundamental thing to know about patients at the time they hit the door, and a part of an admission assessment is which group are they falling into? Are they the group that's been stable in function, or are they the group that's declining in function? So what happens from the time of admission to discharge? So we're going to take this in two groups. We're going to first look at the decliners, and then we'll look at the ones who hit the door without declining. So, if you think about the course of medical illness, like if you come in, dehydrated with a bump in your kidney function or abnormal sodium, the things you get when you're dehydrated, that's all better 90% of the time by the time of discharge. If you have pneumonia, almost always the oxygenation is better. So that, physiologically the illness is getting better. So what's going on with function so that's not getting better? So it turns out if you take these 43% of patients who came to the hospital with a decline, only 20 of those 43 are recovered by the time of discharge, so less than half. It's less than 50-50 that they'll recover. 18% don't recover, and actually 5% get worse, which is kind of remarkable, that as the illness is being treated, function is getting worse. Surely we would hope that those who come to the hospital without functional loss will leave without functional loss. But remarkably, of those 57% who come with stable function, 12% of them, that's about a fifth of them, actually decline in the hospital. So again, physically better, I should say maybe physiologically better in terms of the admitting diagnosis, functionally declining while they're in the hospital. So this is sort of what happens when you put it all together. So a part of my job at UCSF is training research fellows and talking to them about how to give presentations. So this is the type of slide I tell them never to give. One of these slides with arrows flying over the place, which you can't help but feel confused when you're looking at it. Though that is kind of the point, so that the point of this is not to follow every arrow, but to know actually these arrows that are sort of representing what's happening to function over the course of illness, that's actually this sort of instability and chaos. This is kind of what's happening to our patients. Function is very unstable over the course of acute illness, and I'll present you some data in a few minutes that shows through all this chaos, it really matters a lot whether you end up in that 65 or 35 group. That group that ends up in that 35% does really badly over the long term. So that, you can't really improve a problem without measuring it. So that if we're interested in improving function and we see that it's unstable over the course of hospitalization, part of our task is to really measure it and know what's going on with function. So what does this all mean for the dynamics of hospital disability? So disability is changing rapidly over the course of acute illness. One problem with some of the terminology of hospital-acquired decline is that we actually are talking about something that's a little bit more complicated. So disability at discharge is the combination of two things. It's the failure to recover pre-illness function during the hospitalization, and then there's a problem of new disability during hospitalization. These two groups might need somewhat different things. So that when we're thinking about reducing disability, there's really two things going on. It's how do we rehabilitate function in those who came to the hospital with some new disability? How is that part of their illness management in the same way antibiotics are part of pneumonia management? And then how do we actually prevent them from getting worse while they're in the hospital? So I alluded to the fact that the people who have hospital-acquired disability have a really bad prognosis. This is a study Cynthia Boyd did a number of years ago that actually took these same patients and said, what happens at 1 year to those who left the hospital with ADL disability? So it turns out if you're in that 35% group with new functional deficits at the time of discharge, the 1-year outcomes are quite bad. 30% by the time of 1 year have recovered, so they actually, in fact, go back to their baseline function. 28% survive, but they're not recovered. They are permanently disabled. And 42% have died. So sometimes, as one who does work in this area, I'm sometimes surprised by my own data because I used to give talks like this that says this is a bad problem. I guess I didn't really believe how bad it was. So probably many of you have heard about how bad hip fracture is. That, after hip fracture, about only a third of patients return to their baseline function after hip fracture. What's interesting about this is these numbers are virtually identical to the numbers you would see for hip fracture. I mean, almost to the decimal point. That hospital-acquired disability has about as bad of a prognosis as hip fracture. It turned out in this study that 1 month recovery was a big predictor of 1-year outcomes. So if you recovered by 1 month, there was a 56% chance that you would remain at baseline function at 1 year. So hardly a great statistic, but maybe not horrible. But if you didn't recover by 1 month, future recovery became very unlikely. Only 17% of that group returned to baseline function at 1 year. It was actually interesting. Those of us who were working on this project had a little bit of a debate about how we were going to spin these results. So there was one group of us who said, this means we have to be really aggressive about rehabilitation and at 1 month after discharge. There was another group of us that said, this means we have to actually be really aggressive about palliation, that we have a group that's going to be doing really badly and we have to prepare them for this disability. The correct answer was all of the above. We actually were a little bit behind the times. I think we're now in an area where we realize actually rehabilitation and palliation are not inconsistent with each other. We can do both at the same time. And I'll talk a little bit more about that at the close. So now that we've answered that this happens a lot, let's think a little bit about who's at risk and some of the patient and hospital processes that put patients at risk. So I think even for those of us who deal with this problem on a day-to-day basis, it's kind of useful to think a little bit about actually what is it that's going on with disability in older persons? And how is this different from the ski accident or automobile accident that causes disability in younger patients? I think the fundamental thing to understand is that disability in older persons is usually quite insidious. It usually is not some sudden thing that happens, boom, and you're disabled. So that it's sometimes the case with stroke and sometimes the case with hip fracture. But that's not the typical course. It's usually very slow. So it's this slow progression of functional impairments. So what you have is an accumulation of vulnerabilities, and it's not, often in medicine we're taught to think of differential diagnosis, what's the cause of something, but in geriatrics that concept doesn't work very well. It's actually, the answer is what's the cause, it's lots of stuff. And actually what causes disability in older people is the accumulation of lots of stuff that just over time impacts them. So we often think about disease, and that's a big part of it, things like heart failure and diabetes, but it's also other problems that are very important in geriatrics, things that we don't classically think about in terms of diseases, things like cognitive impairment, but also social and psychological factors. For example, depression is a very important determinant of disability. So you have this accumulation of vulnerabilities, but then there's a precipitating event that pushes older persons over the edge into frank disability. So the model of disability is this combination of vulnerabilities and then a precipitating event that pushes you over the edge. So where hospitalization is really crucial is that illness and hospital processes are the most common precipitating event. When you look at when older people become disabled, about half of disability in older persons can be directed or accounted for by hospitalization as the precipitant. I sometimes describe this in terms of a Humpty Dumpty phenomenon, so that Humpty Dumpty is sitting on a wall and you think of the egg bouncing and a little bit frail. And it's actually, the nursery rhyme says Humpty Dumpty had a great fall, but it's actually a little fall. It's just a tiny push, a little pneumonia that pushes Humpty Dumpty over the edge. So that's kind of often how I think about hospital-acquired disability. So this is a very age-oriented phenomenon, so that, the risk, there's been some studies in our group that actually shows in socially disadvantaged patients, you can even start seeing this well before the age of 70, so that there are people who age well before their time. But just in the stuff we've looked at, the rate raises from 23% among those who are 70 to 74, all the way up to 50% in those who are 85 to 89, to a pretty whopping 63% in those who are over the age of 90. Again, accentuating the problem that, gosh, if you're 85, it's more likely than not that hospitalization is going to push you over into disability. So what are some risk factors for hospital-acquired disability? So many of you have worked in gerontology, so you might have heard people use the phrase the 3 Ds. Depression, dementia, delirium are these basically 3 problems that really put older people at risk for disability and sort of often conspire together. So depression. So there's been a number of studies that show that high depression scores are associated with a higher disability risk. In hospital populations, those who are depressed are about 2 to 3-fold higher risk for disability. In terms of geriatric disability, depression's a really bad actor. So I was mentioning one of my side gigs is research training in my division, and people sometimes come to me from all sorts of disciplines looking for projects. So one of the sort of things I almost say jokingly is, if you have data on older population and you're looking at any problem, if you have access to data on depression, whatever your problem is, you have a paper, because I can guarantee you depression will be associated with whatever problem you're looking at. And it's invariably true. I mean, depression is just a really bad actor in aging. Then cognitive impairment, which includes both delirium and dementia, and the two of them act synergistically. So if you have both, risk of disability is really high. So delirium is associated with a 3-fold risk of hospital-acquired disability. Dementia, which is generally measured by a failed cognitive screen at admission, is associated with a 4-fold higher risk. Simple measures often predict who's going to be disabled, so that a study that was done by Elizabeth Lindenberger a number of years ago basically showed that just simply using a cane or a walker or reporting a balance problem at the time of admission was associated with a 3-fold risk. In aging, social factors are really important. As we've known for over 100 years, social poor social function actually is often a stronger predictor of health outcomes than classical measures of health. So things like limited social support and poverty have also been shown to be strongly associated with hospital disability. Well, okay, so there are things the patient brings to the process, and then there are things that we do that maybe promote disability, especially in those who are at risk. So I'm going to overview 3 of these areas. One is limited mobility, and the group of you in this room have probably thought about this problem of limited mobility collectively more than anyone in the world. Then there's things we do to induce delirium, and then there's things we do that worsen malnutrition. So many of you have probably seen this study, and I know Dr. Liu has referenced this study in her work. So this is also one of my favorite. The best research studies are sometimes these studies that look at the elephants in a room, that they do these studies that are so obvious that no one else bothered to do it. But they describe a problem so vividly. So this is a study that was done by Cynthia Brown at the University of Alabama VA Hospital. She basically took patients who were able to walk before they got to the hospital, and she put accelerometers on them and just asked, what does a patient do when they're in the hospital? So the results are really striking. On an average day, 83% of one's time is spent lying in bed. That's over 20 hours. 13% sitting, and only 4% standing or walking, less than 1 hour a day. So basically, the study vividly showed maybe what we knew to be true, but documented it in a vivid way, that hospitalized patients are put to bed and stay there. And this study has been repeated elsewhere, and this is not just a problem in the US South, it's a problem all over the US, Canada, and the world. So this was a related study done by Anna Zisberg at the University of Haifa in northern Israel. So she went one step beyond this and said, what happens to people based on how mobile they are in the hospital? So she took 525 Israeli medical inpatients, and she also used accelerometers and looked, well, what did they do in terms of their mobility? So this is actually, when I say high mobility, this is like not running a marathon when you're in the hospital. So high mobility basically meant that you on most days got out of your room. And intermediate mobility means most of the time you got out of bed. And low mobility means you didn't even get out of bed. So very basic level mobility. So those who had high mobility had a 13% risk of being disabled at discharge. Those who had intermediate mobility had a 35% risk of being disabled, and those who had low mobility had a 71% risk of being disabled. So nice, simple evidence that basically suggests that the work all of you are trying to do to mobilize patients in the hospital really, really matters. So this is like a vexing problem. So why is it that patients are so inactive in the hospital? And part of this is that we actively restrain them or give them tethers. So earlier in my training, restraining patients was a really big problem. And I think fortunately, that problem's not fully resolved, but we actually don't do like what we call physical restraints, where we restrain patients who maybe have agitation anymore. But we do a lot of restraints that are semi-active, and we don't think of them as restraints, but they are restraints. So an IV pole makes it almost impossible to move. That oxygen we put on, and we do this not because, we actually do this because we're good people. We're trying to help our patients. It seems so kind to strap that oxygen on a patient. But that oxygen actually means that patients are going to be kept in bed. So you have to remember, when you're looking at this thing called the pulse ox, even if it's abnormal, it's actually, patients don't really get harmed by low oxygen until the pulse ox drops below below 90 to 92. There have been studies in the palliative care literature that even if the patient's complaining of dyspnea, oxygen doesn't help them feel better unless they actually have a low oxygenation. So that oxygen actually just is not generally good for symptomatic relief unless you actually have a low oxygen. Things like monitoring leads, so the EKG leads. So when I ward attend, it seems that at my hospital over the past few years, like almost every patient seems to have to start out in the TCU, which is basically transitional care unit, where they get like monitored. And when you ask the house staff, well, why are we doing this? It's because, well, the patient's sick. It's like, well, but why do you need to monitor the heart rhythm? There's a sense like, oh, okay, we want to be careful with our patient. We want to watch them more. But we don't actually realize there's a cost to that, and we're actually restraining them with those leads. And then there's the urinary catheters. There's a great paper by Sanjay Saint, who's actually just a little bit south of you in Ann Arbor, who wrote this paper where he called the urinary catheter a one-point restraint. Basically, a urine catheter assures that your patient will be in bed for the duration of their hospitalization, especially if we put it in and then forget to ask every day if they still need it. I shouldn't, the gods on the Osler Medical Service, this is the Hopkins Internal Medicine Training Program where I train, might strike me down, so don't tell anyone I'm saying this. But when I trained, I was trained that every patient who had heart failure needed a urine catheter. And that's because we had to measure these I's and O's. So it was the only way to accurately measure I's and O's and measure the fluid intake. That was technically true. It probably was, the most effective way to measure what was going out. But it never occurred to us that there was this great cost of that information. And we often think about the infectious costs of urinary catheters, but probably the worst cost is the immobility. And sometimes when we think about these devices that give us information in patients, we don't think about it in terms of the usual risk-benefit equation. It's like, okay, there might be a benefit, but there's also a risk. And does the benefit outweigh the risk? With a urine catheter in medical in patients, the answer is almost always no to that question. So delirium. So delirium is classically considered an acute confusional state characterized by inattention, disorganized thinking, waxing and waning consciousness, and sleep-wake disruptions. So that, the patient's often sitting looking a little confused and their speech is slow, and you actually, even though you should spend more time with them, you spend less time with them because they're not talking to you very much. The kind of person who they're 80 and their past history is they were an accountant, yet somehow they can't rapidly count backwards from 100 by 7, and we're not trained for that to be like very abnormal. So delirium can be hyperactive, the patient pulling out all their IVs, or hypoactive. I think the reason we miss it so often is that the hypoactive form is considerably more common, which is probably why it often goes unrecognized, that the patients are actually not problems. If anything, they're easier. They're just sitting there. They'll only become harder if you talk to them and realize something's going wrong. So delirium is really bad. So Sharon Inouye has done a number of studies in this area, and your speaker yesterday, Ed Marcantonio, has done a lot of work in this area. No matter what outcome you look at, delirium increases the risk of that outcome. It increases disability risk, it increases mortality risk, it increases length of stay. When I was a medical student, I was trained to believe that delirium was a transient problem. We're now learning that it is not a transient problem. It often lasts a long time. If a patient is delirious during the hospitalization, they almost certainly will be cognitively abnormal when you send them home. And it may last forever in some patients. It increases the risk of dementia. So it's sort of interesting. We often talk separately about delirium and hospital disability, which might be a historical accident, that those who studied these problems were different people. They probably are very overlapping, and the things that cause hospital disability are probably about the same things that cause delirium. But in the work from Sharon Inouye and Ed Marcantonio, the processes that seem to promote delirium are things like immobility, so same thing that causes hospital-acquired disability. Sleep disruption seems to be a really bad actor in delirium, so things like vital signs that wake patients up at night. There's been some studies that show that maybe being in a hospital has a noise level of maybe, being on an aircraft. So noise and daytime sleep, things that cause patients to sleep during the daytime and disrupt sleep-wake cycles. Sensory deprivation's been a big actor in all studies of delirium. So patients often don't bring their visual aids to the hospital. They often don't bring their $3,000 hearing aids to the hospital, so they can't see well and they can't hear well. There's a direct link between the number of medicines you start in the hospital and the risk of delirium, especially psychoactive medicines and sleeping pills, especially the geriatrician's most hated drug, Benadryl, or diphenhydramine, and then dehydration. So basically, both dehydration patients come into the hospital with, but dehydration that happens during the hospital. So finally, malnutrition seems to be a big actor for hospital-acquired disability. So most patients in the hospital lose weight, and muscle loss during the hospitalization is very common. If you look at a hospitalized patient between the time of admission and discharge, so albumin, a measure of body protein stores, drops on average about this is actually half a gram per deciliter during the hospitals. So what do we do to cause this? The nothing by mouth orders that are very common. So the patient's scheduled for a procedure that gets delayed, and then they have the procedure at 2 and they've missed breakfast and lunch, and then we forget to feed them. Lack of assistance with eating. Sometimes when I ward attend, an experiment I do is just, pull up the tray and see how much patients have eaten. And in some cases, patients really aren't hungry, but in other cases, it's because, they can't, those little plastic things and, things that's hard for people who have, arthritis to open them. So sometimes it's just, we make it too difficult to eat. Oh, and then there's the overly restrictive diet orders, one of my pet peeves. I like to emphasize to our house staff that hospitals are not prisons, so patients can eat whatever they want, so that we put patients on these diets that they really don't like. And this is actually not just touchy-feely, that, it sometimes mystifies me. So we have somebody in a hospital, we're trying to normalize their glucose and we're trying to control their diabetes, and it mystifies me why we would want to control their diabetes on a dietary regimen that has nothing whatsoever to do with what they're going to eat at home. So that we need to be more liberal with diet orders. So this was another study done by Anna Zisberg in Haifa that showed that all this stuff really has implications for disability. So she looked at how patient vulnerabilities and hospital processes both contribute to disability. So looking at 684 patients, she looked at patient risk factors and hospital processes. And the key hospital processes were dysmobility and continence care, which were largely catheters. She found that all these processes together, these things that we've talked about, can explain about 64% of hospital-acquired disability. In her work, mobility and continence care were implicated as key precipitants of the disability cascade. So patients who were immobile and patients who had urine catheters during the hospitalization were at highest risk for hospital-acquired disability. And this led to disability at discharge that often persisted after discharge. So, how can hospital disability be prevented? So I'm going to briefly talk about the ACE unit, or the acute care for elders unit, not because it's the only thing out there, but the process of the ACE unit give us an avenue to think about how hospital disability can be prevented. So can functional decline be prevented? So some of the first thinkers in this area and interventionists in this area decided to put all this together with a care unit called the Acute Care for Elders Unit, or ACE unit. So this was developed by mentors of mine at that time in Cleveland, Seth Landefeld and Robert Palmer. And the concept was, okay, we've been describing this problem of hospital disability for so long. How can we prevent it with better hospital care? So the concept was to redesign hospital care and reduce the rate of functional decline in the elderly. So the concept is, it was based on some sociologic concepts of personal environmental fit. So they sort of said, well, we usually ask patients to fit into the hospital. What if we redesign the hospital to actually fit the elderly rather than the other ways around? So ACE units combine environmental change and process change. So ACE units, a big part of this is environmental redesign. So part of this is geographically delineated units that encourage mobility. So things like carpeted floors that make it easier to walk, good lighting, common eating areas that encourage patients to eat in a common room instead of in their room. Things like a quiet environment like soft phones, vibrating beepers, closed doors, avoiding vital signs at night, orientation clues, so like large calendars and clocks so patients know what day it is, and things like that help with sensory aids. We mentioned that sensory deprivation is a big cause of delirium, so easy access to low vision aids, assistive hearing devices, and things like pocket talkers. So a big part of the ACE unit is the interdisciplinary team. So what this generally means is joint assessment by nursing, medicine, social work, pharmacy, and physical therapy. So the team works together to formulate daily plans. So it's one thing to talk about an interdisciplinary team, it's another thing to operationalize it. But one thing that seems to have come out from all the literature on prevention of hospital disability is that simply having every person on the team write notes in a chart doesn't seem to do anything. That you actually have to have a process where the interdisciplinary team members talk to each other and actually don't make separate plans, but make plans based on consultation with each other and by working together. So ACE units also at their cornerstone include processes to enhance mobility. So this includes things like standing orders for patients to be out of bed, easy access to bedside chairs, and limited placement of bladder catheters and other tethers, with explicit daily review to think about, is that IV pole still needed? Is a catheter still needed? Now, I know this is what a lot of you are working on. This has been a vexing problem for many years. So, you know, on the one hand, it seems easy to say, well, why the hell can't we just get the patient out of bed and walk them? You know, just a very basic human function that human people should do for each other. But this has been a big problem for a number of years. And I think, you know, even in the hospitals I work at, you know, it's been a very hard problem to deal with, so that, you know, you have well-meaning people who just together can't seem to make this happen. So at the VA hospital where I work, one of the problems becomes like, well, who's going to do it? And maybe the problem is not who, but we should be thinking about this as a collective problem. So it's not you or me, but it's us. But you know, so that, you know, on the one hand, you know, it's certainly part of nursing, but we have nurses at our hospital who are very overworked and are already working at 120%. So when we say, well, walk your patient 15 minutes a day, when you multiply that by 8 patients, that's 2 hours. So, you know, it's not just telling the nursing staff to do it, but it's also advocating with our hospital leadership about, well, maybe there should be a lower patient load so they can do this. You know, well, then there's physical therapy, but physical therapy does the initial assessment, but then that's a very high-cost way to walk patients. So part of the problem is that there's actually nobody on the medical team that's often staffed or, you know, given this role. So here's one of many examples of a program that's tried to really address this. So this is an interesting program developed by Nikki Hastings in the Durham VA. So, and this is called the Stride Mobility Program. So this was basically a collaboration between physical therapy and groups that are variably called mobility aids or recreation therapy. So that on the day of admission or the day after, there's a mobility assessment by the physical therapist. And that includes things that physical therapists do, like gait and balance assessment, prescriptions for mobility aids. And then the physical therapist, by and large, turns this over to a recreation aid and gives advice about safe ambulation and how to use the mobility aids. And then there's daily supervised ambulation with the recreation therapy assistant, usually on the order of 20 minutes a day. There's also education of patients and families about how to get the patients out of bed. So in this group, their initial evaluation, they looked at 92 STRIDE participants and compared this to people who were eligible but didn't participate. So only one fall out of 92 in these participants, which actually happened not during the daily walk, but happened in another setting. The length of stay was reduced by 1 day in the STRIDE participants from 5.7 to 4.7 days, and much higher rate of discharge to home instead of a nursing home from 74% to 92%. So preliminary evidence that mobilizing patients in the hospital makes a difference. In terms of ACE processes, is another big process beyond mobility is polypharmacy. So a lot of ACE teams include pharmacists as part of the team who often round with the team, and daily review of medicines. We mentioned that the number of medicines you start in the hospital is strongly correlated with the risk of delirium. So minimizing drugs associated with delirium, but also introducing behavioral approaches to try to treat delirium instead of drugs. So behavioral approaches for agitation, behavioral approaches for sleep. So one of my favorite sleep protocols is Sharon Inouye's Help Sleep protocol. So this includes quiet environments, avoiding nighttime vital signs, back massage, and warm milk. It's kind of remarkable that the things that help are so low tech and so common sense sometimes. So the other part of ACE is what is often called planning to go home. And this is intentionally called planning to go home instead of discharge planning. This is sort of meant to kind of invoke some cultural change. So discharge planning is like reduced length of stay, free up the hospital bed. Planning to go home is what does the patient need when they go home. So it's not motivated by bed utilization, which often comes late, but it's motivated by thinking what the patient needs, which actually starts at the beginning of a hospitalization. And it's really grounded in functional assessment. So it starts on admission by thinking about what the patient's functional needs are and thinking about what function they need to go home. It involves assessment of patient and caregiver needs and explicitly thinking about, what is the patient's home environment and what do they need to function at home. So this is a study that was done by Ryan Grayson at my institution, and I thought it was an interesting perspective on how can we better think about discharge planning. So in the US, we're now all obsessed about hospital readmission. And that's in part because Medicare is penalizing hospitals that get readmitted. And the way we're often going about this is we're micromanaging medicines, and we're really focusing on the issues related to the medical diagnosis. So Ryan did these in-depth qualitative interviews with 24 older patients who were discharged from San Francisco General Hospital, a safety net hospital, and found that it's actually more the geriatric things, not the biomedical things, that are really bothering patients after they go home. So he asked them really what problems were they having when they went home. So it wasn't their medicine management, but it was dealing with functional limitations and limited mobility. San Francisco, almost all homes are built on stairs, so if you can't get upstairs, you become a prisoner. And if you have a home in San Francisco, it's $1 million home. Social isolation and limited support from family and friends, so people needed visitors. And at the safety net hospital, it was often challenged as a poverty in the home environment. So they knew about their post-discharge visit, but they didn't have $25 to take the cab ride to go to their visit. So sometimes some of the things that we're thinking about are actually more based on functional and patient needs. Okay, so you put all this together, the ACE unit with improved discharge planning, improved mobility, decreasing polypharmacy. Is there any evidence it works? Well, there have been a number of studies that show at least works some. So this was the best study that we found in terms of the impact of ACE units. So it was a meta-analysis that combined 5 studies of ACE units. So ACE units collectively increase the chance of discharge to home by 30% and reduce the risk of disability at discharge by 18%. Other outcomes included decreased length of stay, and actually the cost of the ACE unit was made up by the improvement in length of stay. Lower risk of readmission, and patients, physicians, and nurses who worked on ACE units all seemed happier than those who worked on traditional units. So ACE units are not the only intervention out there, so just briefly noting a few other interventions that you should at least know the names of. So the geriatric evaluation and management unit is very similar in design to the ACE unit, but rather than starting at admission, it starts usually after the patient is stabilized. So it's interdisciplinary care after stabilization, focused on rehabilitation. And these units, similar to ACE units, decrease the risk of nursing home stays and decrease disability. The HELP unit developed by Sharon Inouye that focuses specifically on delirium, so things like sensory deprivation, preventing dehydration, preventing psychoactive medicine use, reduces the risk of delirium by 33%. So what doesn't work? This so hurts as a geriatrician to say, but comprehensive inpatient geriatric assessment does not work, at least when it's used alone. So just simply having every specialty and field do its assessment and make recommendations doesn't work if you don't have the interdisciplinary team acting together and have some way of actually implementing recommendations. Making recommendations without thinking about implementation tends to be ineffective. So the general overriding component seems to be multidisciplinary assessment and collaboration. So how am I doing time-wise? Am I okay? 2. I'm going to leave time for questions. So I'm going to basically, I have a caveat I often like to mention, but I'm going to mention this one quickly, is that I think when we talk about hospital disability, so our goal is to prevent hospital disability and delay it as much as we can. We do have to keep in mind that all disability is not preventable, that actually most older people do have a phase of disability, so that we can probably reduce the risk of disability about 30%. But part of the point is all the stuff we're doing really matters a lot whether or not we're preventing disability. So I think we have to remember that as we're trying to prevent hospital disability, there's really 2 aspects of this, is that one, we prevent disability when we can, but one of the other things we should be thinking about with our assessments is when we can't prevent disability, we have to remember what the needs of patients who are becoming newly disabled are. So that part of the role for our hospital teams is also to think about how can we better prevent and manage the new functional impairments and needs that caregivers are going to have. So sometimes one thing we want to do is actually prevent this disability, but when patients are going home disabled, we need to think about, well, what are going to be the caregiver needs? What are the home supports patients need? I think one of the things, we actually often do that. A lot of the studies of hospital disability have not given us credit for that because we don't measure that. So one of the important things we do, even when we can't prevent disability, is when we recognize it's occurring, we can better help patients and families through the process. So that I think I think there's great work being done preventing disability, but let's also remember to help the needs of patients who are becoming disabled. I think with that, I'm going to close. And let me summarize a few key points. Many older persons develop new disability during hospitalization. Disability has a poor prognosis and it's often permanent. Hospital processes often contribute to the development of disability, and better models of hospital care, such as the models that all of you are developing, can reduce the risk of disability. So thank you, and thank you for inviting me.
Covinsky, do you want to take some questions?
I'd be thrilled to. So, any questions, comments, or?
Yep, there are microphones up the stands.
So when you're looking at your difference between your baseline, sorry, tall, and a physio, I should stand up straight. When you're looking at your baseline at 2 weeks prior to admission to your admissions, and you looked at that decline, was there a predictive tool that you generated? And if so, can I find it somewhere?
So this is, so the question is, can we predict, is there a way to predict who's most likely to decline
in hospital.
in the hospital?
Right.
Okay.
So your study showed, well, I'm not sure if it was yours, but the study showed that from 2 weeks prior to them having that hospital admission, and so then you had, what was it, roughly 50% stayed stable and 50% declined.
So yeah, so that there have been tools that have been developed to predict hospital disability, so that have focused on, at the time of admission, can you predict who's most likely to be disabled at the time of discharge? So I can pull the reference for you and give it to you later. So the first author it's Mehta et al., M-E-H-T-A, if you want to look it up, Mehta, who actually did develop a prognostic model. So the key factors are, as you would guess, who's most likely to be disabled at the time of discharge. Those who actually came into the hospital with decline are much more likely to leave with decline. But the other big risk factors in that model were depression, delirium, instrumental activities of daily living impairment before discharge, so things like not being able to take medicines without assistance, and having more than like 3 diseases. So that there actually are ways to overall predict. I mean, I think it's sort of interesting though, it's like when you have something that's so inordinately common, we've debated, there's been these actually debates in the geriatric literature, and I think they're a little bit unsolvable because there's rationales for both. Some have argued, should we focus these prevention approaches on those who are at highest risk, which on the one hand often makes sense in terms of resources. On the other hand, well, what do you do when 30% of the population is going to develop this problem, and merely being age 85 puts you at 50% risk? So that, there's another argument that says the risk is so high that we should just focus on all older patients.
Thank you.
Can you let us know who you are and where you're from?
Sure. Thank you for your presentation. My name is Bo Johansson. I'm from the North York General Hospital. I'm interested in your perspectives on pain and symptom management and how a lot of the drugs that we use to treat pain in the elderly, or even undiagnosed pain in the elderly, contribute to those 3 Ds that then precipitate the decline you're talking about.
So this has been what you're talking about, it's become a hotly controversial issue. So we've moved from, pain as a vital sign to avoid opioids in everybody, and probably the right answer is somewhere in the middle. Where this becomes really complicated in the elderly is that opioids are a risk factor for delirium and other problems, but untreated pain is also a huge risk factor for delirium. So if you look at hip fracture, if anything, there seems to be more of an association with untreated pain. And probably acute illness is probably not the time to be sparing in terms of pain medicine. So that I think the answer is, I think we can go too far with not treating pain, but sometimes we're not aggressive enough in terms of really closely titrating the dose and actually using no more medicines than necessary, and back titrating when the pain is treated. The full answer to your question is that we actually don't know exactly the right pain regimen, but I think we need to be a little bit careful about being too cautious about treating pain.
Great. Thank you so much.
Sure thing.
Hi, Sylvia Davidson from Baycrest Health Sciences here in Toronto. Great kind of overview of the issue. I wonder if you would have a thought on, do we get these individuals out of hospital as fast as we can, since much of what we're talking about we have contributed to? Because I find that there's a lot of system conflicts, and there's probably lots of individuals in the room right now who are going, yes, we have to keep these people longer because you're saying that we've got to look at this, this, and this, and yet the systems are saying we can't keep them longer. I just wonder what your thoughts are on that.
That is a really good question that's been actually also hotly debated. So this is, if you talk to 3 geriatricians, you'll get 3 different answers on this. There are people in the U.S., so Bruce Leff is the most prominent among these, who have actually advocated for this hospital-at-home concept. So when you think about it, if you have a patient who's not in the ICU, it's almost technically possible to do everything that we do in the hospital at home. It takes a lot of coordination and work, and there's something to be said for that. I think getting patients to their home environment as soon as possible is generally good, but the motivation has to be what's best for the patient, not what's best for the hospital utilization department. And that you can't send a patient home who actually can't function at home. And we can sometimes be too quick to assume that the daughter or the spouse is free labor that's able to do things that they can't do. So that, I think sometimes when we say hospitals are bad, so we have to get patients home as fast, I think we can sometimes be too quick to say that the answer is to get the patient out of the hospital rather than making the hospital less bad. So that's not that's a little bit of a hedging answer, but maybe there is something in the middle there.
I was just wondering, if people come in the hospital and they're at their baseline at hospital, a lot of times physio will be involved, like get involved initially and continue to follow them. But I'm just wondering, with the limited resources of physio, would be better to target the people that come in with a disability, like the people that don't have a disability, you maintain them at what they were doing at home. Like you find out what they were doing at home and maintain that. And physio doesn't really have to get involved. And then physio can focus their intense resources on the ones that came in with a disability to prevent them from going further.
Yeah, I think, and this is, I think, something that a lot of you in the room have thought about more than others, is like what needs to be done by physical therapy and what needs to be done by recreation therapists, or even those who are trained in walking, or even trained family members, who are trained to help walk the patient in the hospital. So that, I think a case could be made that those who are not disabled at the time of admission maybe don't need the full expertise of physical therapy, but they need somebody to walk them. The problem is they're actually, that person to walk them is often not there. And then, gosh, they do need the expertise of physical therapy because of what we've done to them. But no, I think this kind of triage in terms of if we disaggregate what do we need to do to walk patients, what needs really the higher level expertise of physical therapy, and what basically needs just the very basic, human touch of somebody to help walk and safely walk a patient.
I'm Brenda Henderson. I'm a physiotherapist at Grand River Hospital in Kitchener. And I wanted to comment on your comment about hip fractures versus immobility. Anecdotally, I would actually say that immobility over 25 years of practice has a bigger impact on people's morbidity, mortality than hip fractures do. And I wondered if you could comment on the sort of hyper-focus on falls prevention legislation and policies in hospital, and whether or not that's had an impact negatively on mobilization of patients.
You're going to get me agitated. So, which should be treated behaviorally and not with drugs. But it's so Medicare in the U.S. in its infinite wisdom decided that they would penalize hospitals for falls. At the time this happened, Mary Tinetti, who has probably done more in the U.S. to think about falls and how to prevent them, wrote about what a bad idea this was. And it had no impact whatsoever on moving Medicare in terms of this policy. That I totally agree with what you're saying, is that, yes, falls are bad, but sometimes, prevention of falls at all cost often is even worse than falls. And actually, it's not true that we're preventing falls. So that it is, in fact, true that by and large, if you chain a patient to bed in the hospital, you will prevent a fall in the hospital. Now, in practice, you often don't, because patients don't get out of bed and then they fall going to the bathroom. But we're just moving all those falls to the home. They're still having all those bad events. So that we're actually not preventing at all. I actually talked to a number of clinicians in my hospital who I tell them, there's actually studies that show, so like bed alarms are the rage all over the US. I don't know if they are in Canada. But so bed alarms are kind of now an electronic restraint. There's actually pretty good evidence that bed alarms don't work. And no one wants to believe it. But the evidence is pretty strong that they don't work and they don't prevent falls. And it's kind of like, a cheap way, it's a cheap way of not doing human monitoring instead of we're not doing what we need to actually work on a one-on-one basis with patients. So now we actually can centrally, in a 1984 style, monitor patients. So yeah, I that's a short way of saying I totally agree with you. We've gone way too far with, the way to prevent falls is not to keep patients in bed. Great.